Today's conversation honors the memory of Cathy Shine. Cathy Shine was a remarkable woman who turned an experience of trauma into a legacy of a healthier, more just world. After being restrained against her will while in a hospital recovering from an asthma attack, she went on to become an author and advocate for patients' rights. Before her death in 1992, she wrote a book published by the Sentencing Project on race-based discrimination in criminal justice proceedings. Her work brought her into contact with Professor George Annis, the director of our Center for Health Law, Ethics and Human Rights. Professor Annis would cite her experience when arguing in the New England Journal of Medicine for the right of patients to refuse restraints. Cathy Shine's legacy continues to help advance the conversation about supporting the health and dignity of patients. We are very grateful to the Shine family for helping us establish this lecture to continue this conversation. I will now turn the event over to today's moderator, the intellectual architect of this event, Professor George Annis. Professor Annis is the William Fairfield Warren Distinguished Professor of Health Law, Ethics and Human Rights at our school, and he will introduce and moderate the conversation with today's speaker, Heidi Kummer. Professor Annis.
Get this one. Okay. Thank you, Dean Goya. It's my pleasure today to introduce our Shine lecturer, Heidi Kummer. We have a slide up, so I don't have to memorize the title of her talk, which is The Case for Patient and Healthcare Advocates, or her primary title herself, which is President of the Patient Advocate Certification Board, a national board, very, very impressive, which is set about to transform the country, I think I'm trying to tell that, into a place where patient advocates are regular occurrences, not just in hospitals, but wherever people have important decisions to make about the future of their health care. Dr. Kummer is very well qualified to take on this job. She has an amazing background, graduate MD, PhD at Philipps University, Marburg, I guess, and that's in Germany, so she had to come here to do her residency, and she did a double residency in anesthesiology and critical care medicine. A lot of it here at Boston Medical Center. Wasn't called that then, but okay. And the way this is going to go, I'm sorry, I forgot the most important thing about your curriculum, is that she's a graduate of the School of Public Health in 2004 in the Department of what was then the Department of Health Law, Bioethics and Human Rights. So the way this is going to go is Dr. Kummer is going to talk, and then I'm going to ask her some questions, and then we're going to open it up to you guys to ask questions, and then we'll open it up to the people on the chat to answer questions as well. Okay, Dr. Kummer.
Thank you. Thank you, Dean Galea, and thank you, Professor Annis, for that very kind introduction. It's an incredible honor to be here, and actually very humbling considering the luminaries who have come before me to give this lecture. But I am the first very proud alum of this school to be giving this lecture, and I'm also the first who's actually going to be talking about patient advocacy, a novel idea that Professor Annis has been proposing since 1974. So thank you for inviting me, and thanks to the Shine family for the gift of this lecture series and for allowing me to share some of Cathy's story. We are in fact here to commemorate Cathy Shine's life and legacy, and in a sense also look at what might have been. So allow me to make the case for patient and healthcare advocates. As you heard the Dean mention, Cathy was a remarkable young woman. She unfortunately suffered from pretty bad asthma since childhood, but had learned to live with this chronic condition and manage it quite well. Unfortunately, during a visit with her sister here in Boston, she suffered a severe asthma attack, and after being reassured that she would only receive oxygen therapy, she agreed to go to the ER. Once in the ER, she did get inhalation therapy, and they checked a blood gas to see how her metabolism was dealing with this attack. It was not good, and the ER physician wanted to intubate her immediately, which Cathy refused, and she was given a little bit more time to see whether the therapy would kick in. The ER physician agreed to call Cathy's father, who was a physician in the UK at the time, who also emphasized to please listen to Cathy. Cathy was actually starting to look a little bit better, and a second blood gas was obtained. But it became more and more clear to her that nobody was listening to her and that intubation was imminent. And so she suggested to her sister Anna that they bolt, which they tried to do, but were unfortunately apprehended by security and led back to the ER bay. Anna was escorted back to the waiting room, and Cathy was forcibly restrained, given some sedatives, and intubated. The second blood gas that showed some clear improvement in her condition was never checked. She was taken to the ICU overnight, extubated the next morning, and sent home. So in addition to suffering from asthma, Cathy was now suffering from what we would these days call medical PTSD. She had nightmares of being forcibly restrained, of being intubated. It was just severely traumatic. And there's no question that the experiences of that day contributed significantly to her tragic death 2 years later, when she again suffered a severe asthma attack, resisted going to the hospital. When she finally did, a similar scenario played out. Unfortunately, the outcome was fatal. So what if Cathy had had a professional advocate at her side that day? Who or what are professional advocates? Now, this is a definition from the Code of Ethics of Professional Healthcare Advocates, and you can see it's quite broad. And this very broad description of who we include in the advocacy world contributes undoubtedly to some of the confusion with the nomenclature. But it's not a new concept. In public health, we're familiar with community health workers, and those programs existed back in Russia in the 1800s. And later you had the Barefoot Doctor program. The WHO thought back in 1970 that community health workers were actually the key to safer health care, among other things because they would be accepted by the locals and would know the local conditions, or what we would consider the social determinants of health these days. Jim O'Connell's street doctor program here in Boston could be considered such an example, and certainly what the late, great Paul Farmer referred to as accompaniment. But when you're talking specifically about patients' rights and patient advocacy, the first patient representative department was formed in the late 60s in New York. And the first patient Bill of Rights was adopted by the American Hospital Association in 1973. But in their article in '74 in the Vanderbilt Law Review, George Annis and Joseph Healy argued that just having a statement about rights doesn't guarantee anything. They're not self-enforcing, and they don't guarantee that a patient's interests are actually respected. So they suggested that one should have patients' rights advocates for, at the time, hospitalized patients. And they chose the term advocate deliberately as someone who is called to assist, defend, and aid. They proposed that these advocates should be loyal only to the patient, that they should have maybe broad experience beyond just formal education, and conceded that who would pay for these services might pose a problem. The emphasis on hospitalized patient was continued initially in the first ACLU handbook on the rights of patients, but was subsequently dropped, I think, with the realization that every patient needs an advocate. The early development, it started to catch on. So the first Masters in Health Advocacy was started at Sarah Lawrence. They are about to offer a certificate course online starting this fall. This is a typical example of the different nomenclatures. You have the geriatric care managers, who now are aging life care, patient navigators, which we'll talk about in a moment, and then the Patient Advocate Foundation provided case management services to those in need. And when Eileen Corinna started her Pulse Center, it was actually a support group for survivors of medical error. The real change to my mind, came in 1999 with the Institute of Medicine's report on To Err is Human, where the suggestion that up to 100,000 people a year died due to mostly preventable medical errors. The response was fairly swift. So on the industry side, you saw the formation of the Leapfrog Group, which was deemed to collect, analyze, and publish data on safety and quality measures in healthcare. They focused on the IOM assertion that it was not about bad people working in healthcare, it was about good people working in bad systems, and these bad systems needed to be made safer. On the consumer side, there was equally growing awareness that you needed an extra pair of eyes and ears for any provider or hospital interaction, and ideally somebody who could guide you through the ever-increasingly complex healthcare system and the maze. And so you see the formation of multiple organizations. These, to my mind, are the most important that were started and have had the greatest impact since then. And last year, 4 of the organizations got together to form the Coalition of Healthcare Advocacy Organizations, which functions as somewhat of a policy arm, if you will. So, okay, now we have an alphabet of organizations and lots of beautiful logos, but do healthcare advocates make a difference? You can't really talk about the history of navigation or advocacy without discussing the Harlem Hospital Navigator program, because that really was the catalyst for all other navigation programs to come. And what you can see here is that prior to their intervention, and we'll get to the intervention in a moment, but prior to that, only 6% of their patients were found with early stage disease, whereas afterwards, over 40% were. And that accounted for the incredible increase in 5-year survival rate. Now, this was a disproportionately poor, uninsured population. Over 90% were Black. The intervention was low cost or no cost breast screening and exams, and most importantly, the institution of patient navigators who would perform the outreach, the follow-up, and the follow-through to make sure that from time of diagnosis to follow-through was shortened. So we've known for over 30 years that targeted interventions in minority populations actually work and make a difference, and yet here we are again after the pandemic and these incredible racial disparities and that we've seen. I mean, it really begs for a more permanent solution. The success of the Cancer Navigator studies propelled people to look at now basic access and at adults with complex needs. We don't have time to go into this. I am providing a link later with all the references, but I ask you to trust me when I tell you that the majority of studies looking at navigation and or community health worker interventions show improvements in these metrics. Shouldn't be surprising and really isn't. So patient satisfaction went up, treatment adherence was better, you had fewer cancellations, and very, very importantly, much lower readmission rates, which we know makes a difference with cost, right? And clearly a better understanding overall of how the healthcare system works. They also showed some limitations, namely, there was tremendous variability in nomenclature, in the type of training that the people had who were used in these studies, scope and duration of practice, the types of intervention, and the funding sources varied considerably. Few only had cost analyses, but again, knowing that things like utilization, readmission rates were reduced, it tells you that there definitely was a cost improvement factor. But okay, how might some of these limitations be addressed? Well, certification could be. So these are some of the benefits of certification, right? Establishing practice standards, getting independent professional competence evaluation, a commitment to public safety, adherence to ethical standards, and to lifelong learning through recertification requirements. But it also enhances visibility and understanding vis-a-vis other professions. And it ideally expands professional development and academic programs. So a brief word about the PAC board. Started in 2012. First exams were offered in 2018. I'm very happy to say our last exam cycle just ended this past weekend, and we are up to 1,200 board certified patient advocates. you see our mission and our vision, and based on already something that, again, Professor Annis and Joseph Healy sort of indicated, we have dual eligibility pathways. So one is through education and the other is through experience. And the founders of the PAC board, even though there were there's overlap with other professions, undoubtedly, they felt that the practice of patient advocacy as a profession itself deserved its own set of domains and skill sets. And so it also included embracing a code of ethics, which originally was formulated in 2011 by the national organization NAC, and just last year was updated by a coalition of us to reflect the landscape today. So virtual care, for instance, which didn't exist then, or the use of patient portals, and we expanded our DEI section. But as you can see from this, ethics constitutes the largest domain in our certification exam. So this is the affirmation from our Code of Ethics, and it's pretty much verbatim taken from the goals that were set out in the Institute of Medicine report in 1999. And so, okay, so those are the goals that we have for how healthcare should be delivered. How do advocates do that? Well, at the heart of what we do is listening, is meeting the clients, and they are our clients, they are not our patients, meeting them where they are. It's figuring out the context, the background, their understanding of why they called us in the first place, right? Making sure that whatever their needs are, we are able to assist them. So in my case, for instance, if somebody needs insurance or billing issues, I will subcontract or refer to one of my colleagues who specializes in that area. I know enough to be dangerous, but not enough to really help people. So then we research whatever they need, whether it's facilities, clinical trials, better a second opinion, whatever it is they need, we research, and then we provide them with the information to allow them to make an informed choice. And once they've made an informed choice, we help communicate that decision, whether we agree with it or not, help communicate that decision to the healthcare team and everybody else who is involved. And we make sure that they have adequate connections and access to whatever resources are there. We collaborate with all the players involved. We empower them to ask questions and make sure that they are prepared for provider visits or hospitalizations. We all know hospitals are dangerous places, and you really should always have somebody with you at every interaction. So who are we? Well, we come from a wide variety of backgrounds, some from healthcare, physicians, nurses, social workers, pharmacists, but IT professionals, people who have worked in administration, people who have worked in marketing are advocates. And many, if not most, of us come to this through personal experience or because of bad personal experiences with the healthcare system. And because we have a desire to help others, we want to try to prevent others from having to go through the same miserable experience that we had. I like to say we share the empathy gene, which I think people in public health do as well. And we often specialize. So here in New England, we have an incredibly active and cohesive group. We have people who specialize in the solo aging space, young adult mental health, complex medical diseases, refugees, et cetera. So it's really quite wonderful. We network and collaborate. I like to say one of the best tools in our toolbox is our Rolodex. I know it dates me, but that's, I don't have all the answers, but I almost always know who to call and who would. And then finally, I believe very, very strongly in the power of kindness. At this point, I just want to take a moment to discuss shared decision making, because what Cathy went through that day in the ER was an egregious and unacceptable example of medical paternalism. But we've also seen patient autonomy taken to the extreme, where you consult a physician for their expertise, and they are not willing to share any of it. They give you a bunch of papers and say, here are your options, you pick. Whether it's out of a sense of liability, as in, well, if something goes wrong, you chose that, I had nothing to do with it. But it's bad. So what we're looking for, of course, the goal and the buzzword is shared decision making, but shared decision making takes time. It requires information and it requires conversation. And many times these days, the physicians either don't have that time or don't take that time. We advocates do. That was confirmed in a recent survey, the full results of which will be published soon. It was undertaken by the coalition in conjunction with the advocate. Over 540 respondents, and you can see the groups that were surveyed. And again, pretty much all groups agreed that working with an advocate enhances communication, enhances more realistic expectations. If they have better understanding of what their options are and what is being presented, they also have more realistic expectations, and it's also leads to much greater shared decision making. So since we're going to assume that the advocates, who are almost half of the respondents, felt they had a positive impact, we'll look at the other two groups. And on the patient side, you can see 96% thought that every patient should have access to an advocate. These were some of the reasons cited, right? They felt more comfortable, more peace of mind, had greater confidence in decision making, felt heard, had a better understanding of what was going on. And clearly communication across all, whether it's family, care team, et cetera, was better. And somewhat interestingly, the providers had a similar sense. Over 90% felt or would recommend working with an advocate. And that's been my personal experience. After the initial, especially for a physician advocate, once they figure out you're not just there to make sure they wash their hands, but you're actually a resource to them, as well as to the patient, they start calling you. And what surprised me a little bit, but makes perfect sense, is that over 60% actually felt that it reduced the burden on them and their staff, which, given what we're going through in healthcare with burnout, is, I think, a very important metric. We can't talk about anything these days without talking about the pandemic. Clearly, I believe that the resurgent and renewed interest in healthcare advocacy is a direct result of some of these pandemic experiences. Patient safety took a huge hit, and it was not just because of staffing shortages. It was also because patients were not allowed to have anybody with them to help keep them safe. I also think that the other driver is the disparities that we saw, and that they simply have been so glaring that can no longer be ignored. On the plus side, the greater acceptance of telehealth made access not just for patients to physicians or clinicians, but also for people who live in underserved areas for access to advocates, since we at the moment still have somewhat of a bi-coastal predominance. And again, it reinforced the importance of having someone at the bedside or with you at all times. And one thing that's not mentioned here that I want to say is I believe it also, again, showed the importance of trust. And who do you trust? And how do you gain that trust? For people who are a little bit more visual learners, this is a very busy slide, but it's Jeff Cooper, who's another local patient safety icon. He was a co-founder of the Anesthesia Patient Safety Foundation. He adapted James Reason's model of the Swiss cheese accident trajectory, and his depiction of what it means to work with an advocate is that the advocate really prevents bad things from happening. And I would emphasize that it's all those other in-between potholes where I think the human approach and the what I like to say, compassion, confidence, and care of the advocate and the patient-centered approach really helps to avoid some of the bad things that tend to happen. Okay, so where are we? We're about 50 years on since Annis and Healy proposed this, and pretty much most hospitals now have a patient advocacy or a patient experience department. But we have to caution, they are usually a hybrid between PR and risk management and only deal with complaints. Those of us who have a vision of an advocate for every patient are well aware of the challenges that we still face. These are my 6 A's, and looking at them, I hope, for instance, the fact that this lecture will help with the awareness part, or the fact that we desperately need more training and education opportunities, where I, of course, feel that schools of public health are the ideal partners to help with that. And the affordability, yes, we are still an out-of-pocket expense at this time, but we are working toward insurance codes, and my hunch is we'll go through more of that in Q&A. And as far as the allegiance, the very first client who hired me right after I started my business had cancer, was being treated here at one of the local cancer centers. She had an assigned cancer navigator, and she mentioned to her navigator that she was thinking of getting a second opinion. And her navigator said to her, "Oh, you don't need that." Because, of course, they don't want you to go outside of the system. And that is when she realized that, oh, maybe I need to get somebody who is actually loyal only to me. So no matter how well-intentioned, and I'm not in any way, shape, or form putting down any of the employed advocates, but no matter how well-intentioned they are, they can't possibly be exclusively loyal to the patient or client. All right, back to my original question. If I did a halfway decent job, each one of you should be able to answer this question now. What if Cathy had had a professional advocate with her that day? Well, you would have had a professional vis-a-vis all the other professionals that she was dealing with in the ER. You would have had somebody who could have supported Cathy's wishes, could have emphasized her knowledge of self and her disease. You would have changed the dynamic, much more likely to achieve shared decision making. And you would have definitely had somebody follow up on that second blood gas result, which we know showed improvement, and therefore would have very likely avoided intubation, certainly avoided restraints, possibly even avoided admission altogether, and the resulting PTSD that would not have occurred. And maybe, just maybe, Cathy would still be with us today. So thank you, and there is a link with references to the talk for later. Thanks.
That was terrific.
Thank you.
Heidi, thank you really very much for that. That was terrific. I think most people, even I, don't know what an advocate is. And your slide you had with all the different terms on, and you wound up talking about navigators in the end. I think people don't know what they are. I think once they know what they are, they can agree with you that they can save lives, and they can actually be a good thing for doctors, not a bad thing for doctors.
Absolutely.
And I think they, not necessarily in some kind of a contest there for the patient, or going to bring more lawsuits, which is what they mostly do worry about, by the way, as you probably know.
Yeah.
So the way this works any way you want it to work, but I'll ask you a few questions, and when they get boring, we'll throw it out to the audience, and then when they don't ask the right questions, we'll find out the people who are online. We apparently have more than 300 people online, so that's terrific.
Great.
That's a giant group. Okay, so you said cost was always going to be an issue. You want to say something about that? Have we thought about who's going to pay for these?
Well, I think it's definitely a hallmark of the system that we are in, that the very first question is about payment, clearly. And it's, unfortunately, in our society, unless you put a price tag on something, it's not considered valuable. So those of us who bring this expertise to the table need to charge for it. It is part of professionalizing it. Some community health workers, and thanks to a recent bill that was passed, Medicaid will actually pay community health workers in certain states. Usually the way it works is people go for a code through CMS, and then other insurers follow. In this circumstance, I think it might actually be the other way around, because we know CMS actually has data. They have a lot of data showing that even a follow-up phone call can reduce readmission rates by significant amounts. And yet they haven't done anything in this direction. Why, I don't know. But I believe that as more private insurers look at this, they will be the ones to spearhead, saying, well, I think we're going to put some funds aside to enable our constituents to have advocates work with them. Because again, if you have a better understanding of what's going on, you have more realistic expectations, you make sure that somebody doesn't get readmitted just by making a phone call after discharge. Things like that can be done by advocates, I think will very, very quickly make the case to fund these endeavors, as ultimately it saves money.
So like a big insurance company or even Medicare could have as a benefit
Absolutely.
the payers,
Yeah.
you can get an advocate.
Yeah,
Call
and
us.
actually I think that the Amazons and One Medicals are going to be the ones who start this. As I said, I believe in this case it's probably going to be the other way around. It's not going to be the usual CMS route. It's going to be the other actors and players. And when venture capitalists start getting involved,
Once they can figure this out, yeah.
Yeah, well, we've seen the first forays into medical advocacy from venture capitalists, so they must believe that there's something there.
Oh, you have seen that?
Yeah.
I didn't mention your company. Can you tell us something about it? 3C?
So it's called 3C Patient Advocacy, and I had been advocating for friends and family for decades, but it never occurred to me to do it professionally until I saw that there was a board certification. And when I noticed that in 2018, I got board certified and I started my company, because again, it makes sense to me to professionalize that vis-a-vis other professionals. And people will say, well, you have enough letters behind your name. Yeah, but the point was, if I'm advocating for a client, I'm not there as a physician. I'm not there as a public health person. I'm there as an advocate, and I should have the requisite certification and credentials to go with that. And that's why I strongly believe that certification is an important part of professionalizing this, this line of work.
How many companies like yours are there?
Oh, George, I don't know.
Okay, no, that's a fair answer.
I have no idea.
You don't have a trade association yet?
We do not have a trade association.
Okay. Well, you did tell me if someone was looking for an advocate, there's networks out there they could tap into?
Absolutely. There are wonderful advocate directories. The very first one actually was, I think, established by Tricia Torrey, who started AdvoConnection. Again, she had a terrible experience. She had a misdiagnosis. It was given 6 months to live. And unfortunately, she's still alive, and that was like 12 years ago. And she realized that something needed to be done, and so she started the first directory of patient advocates. So there's AdvoConnection, then Greater National Advocates that was started by Brad Schwartz, a lawyer in Chicago who went to the ER with a terrible headache, was pretty much ignored because he was a fairly young, strapping guy who, had a headache, and nobody thought there was much to it. And he got progressively worse during his stay in the ER, and he woke up, a couple months later without his 4 limbs. He had become septic while in the ER, and the result was loss of pieces of every single one of his 4 limbs. And his mission in life now is to make sure that patient advocacy is as widespread as possible. He runs a Greater National Advocates Now, which is very much Brad. that it's free for any advocate to be listed, and he has blogs, etc. So that's, and then most of the organizations. So the national organization NAC has a directory. MACA, we have the Massachusetts Health Advocacy site, has a bunch of us listed on there. So you can find, and quite honestly, when I ask how people find me, they frequently say Google. So,
Oh, it makes sense, right?
yeah, I guess.
So you showed the slide of the famous Institute of Medicine study, To Err is Human.
Yeah.
There's a lot of articles being written recently about that. And the question is being asked by a lot of people, why didn't that change anything?
Well, I think it's an excellent question. I mean, the study that just came out doing kind of a follow-up looking at patient safety and finding that still 1 in 4 hospital admissions. Not much has changed, and it remains, medication errors remain still one of the highest or the most prominent medical error. The system is broken. I mean, I feel like a broken record because we all say that. Any and all of us who are involved in this, say this. And again, to me, I never feel like I'm either a physician or a public health person. I am both. And I actually believe that we need to come together more. When you talk to someone in medicine about prevention, they think about mammograms and PSAs and colonoscopies. And when I think about prevention with a capital P, I think of prenatal care. I think of maternity leave, paternity leave, guaranteed early kindergarten, low cost, no cost schooling. What we have learned, I mean, speaking of, the whole safety thing, we've learned nothing. Adverse childhood experiences, we've known that for over 20 years. And what are we doing about it? Trauma-informed care that we talk about, that isn't getting the traction that it needs because guess what? It needs time. You need to have time to ascertain these things. And this is where advocates clearly can help because they can take that time with the patients, with the clients, and then when you go to provider visits, you can even, I frequently send something in advance. If it's somebody I've never dealt with before, I will introduce myself and explain my role. And after discussing with the client, what are the questions we want answered? What is it that we want to know in that 15-minute window that we have? And send that ahead of time to the provider. And so usually you have a much more productive visit. And so, yeah, I think there's a lot, and whether it's trauma-informed care or getting at the adverse childhood experiences that snowball into what we know about addiction, what we know about overall trauma and disease states that arise in midlife. These are all things that need to be addressed. And we're doing a lousy job of it. Even last Friday, an MMS forum, which was great on leadership, had 2 separate tracks. It had a public health tract and it had a medical tract. And I was a little saddened by that because I really feel that what we in public health have to say is important for medical providers to hear, and what we as medical providers have to say is important for public health. We need to break down these barriers because we really are all on the same team.
Let me ask one more, and then I'm going to open it up to people here. Okay. Since it's Artificial Intelligence Day or year or whatever, most of what you seem to say, maybe we got this wrong, is that patients need more information. And AI could give them all the information in the world.
Well, it's not just the information, it's being able to understand that information, right? And if you don't have the requisite health literacy, you cannot understand a lot of the information that's provided.
But theoretically, you could ask AI to explain it to you.
Well, sure, you can use Google Doc, Dr. Google, whatever. Yeah, you can certainly. When it comes to research and things like that, there's no question. Or going through like tumor boards, I think, is one area that people have discussed. AI could be very, very helpful. What concerns me is that we've already farmed out the physical exam, right? Nobody does a physical exam anymore. You're asked 2 or 3 questions so that they know which part of you to image. And, that's it. So we do testing. And I am, if we should have learned anything again about through the pandemic or from the ACEs studies, people are looking for connection, not connectivity. And we can't connect in 15 minutes. There's no way you can get the essence of someone's background, disease, and trajectory with that. And again, AI, great, probably in the no touch, so pathology, radiology, where they can really help with diagnostics. But I am very, very concerned bringing it into the room with patients. And, you look at EHRs, right? They use templates for their discharge summaries and admissions, et cetera, et cetera. And famously, as interns, we all learn how to dictate a discharge summary, and you have sort of stock quotes, right? And so there are templates that exist that say, patient was ambulating without assistance, ready for discharge, et cetera. Well, one of my clients who had was basically functionally quadriplegic and was being discharged to a rehab facility, her discharge summary said she was ambulating without assistance. Well, that can have repercussions for insurance, disability, et cetera, and you have no idea how hard it is to get something like that changed in the medical record. It's a nightmare. If it's bad for those of us who are supposed to be in the know, you imagine what it's like for people who have no connections and no real understanding of this. Is that enough on AI?
That's great. So one thing doctors have been taught is never to change the medical record, even if it's wrong. All right, anyone? Nicole, I think you put your hand up first.
So this was a great talk, thank you. And I couldn't agree more that we need to break down the barriers between public health and medicine. I just think that we're long overdue for that combination, so amen. Is it on? I think I turned it on. There we go. I have a whole bunch of questions, but I'll just start with one and not be greedy. And it is this. You said you think that payment for the work of navigators will begin in the commercial insurance space, not the public insurance space. But something that came to mind for me as you were speaking is the work of Medicaid ACOs, and especially, for example, the Medicaid ACOs in New Jersey that are trying to make it so that people who are vulnerable, frequent flyers in hospital emergency departments find places to live, have people to help them to get food, dealing with basically what we think of as the underlying determinants of health.
Yep.
And effectively, those ACOs are doing a sort of navigator work. So I wonder if there isn't a place to slot in there.
Well, it'd be wonderful if we learn from the successes of those who are doing it. As you know, again, Medicaid still is not being used the same way in every state. There's such variability in it. And as I said, Medicare, CMS has a lot of data, trust me, a lot of data on the impact of navigators and advocates, the way they use it. And I do not quite understand why they haven't moved more in that direction. But what you give as an example, we know and feel and want to provide these services to especially those who can't afford it, right? And one of my colleagues is here today. She, Dr. Brita Lundberg, just started the Massachusetts Health Equity Institute, which is going to look for grant funding to provide advocacy services where a bunch of us are going to volunteer basically to work with them to provide advocacy services for people who can't afford it. I still have quite a slate of pro bono clients that I work with who I've had since before I started my company, and we'll certainly continue that. We're working on it.
Yeah, Chris.
Well, thank you for your compelling talk. Just one observation. I find it interesting how this movement cuts across so many different dimensions of for example, informed consent or shared decision-making and patient safety. We sometimes put those in very different buckets analytically. It's interesting how this at least aspires to cut across. I'm wondering how it rubs against some of the other legal regimes, though, and I wonder if you have examples of patient advocacy going awry, and if you think there's potentially someday a case for licensure, for example, which might require board certification as a condition of licensure. Have you started to see fly-by-night patient advocates, either from the perspective of the patient, or I can imagine sometimes the perspective of the physician who finds it more adversarial than the physician would prefer. So I'm just wondering, that's where a lot of professions end up, and are we on that trajectory towards licensure because of snake oils?
Well, I'm grateful that the 4 mothers, and they were all mothers at the time, who came up with the idea of certification rather than licensure, precisely because of the state-to-state variability, and also, which was hugely important in the pandemic. I think of the clients I have now, 1 is in Massachusetts. All the others are all over the continent, and actually also in Germany. So it allows us to practice everywhere and across state lines, which I think, again, in this time where there is still a bi-coastal predominance of advocates, it helps be able to serve people in underserved areas. We have a very strong code of ethics, as I mentioned before. Are there people who probably violate them? Yes. I mean, is there malfeasance, I think, in just about any profession these days? I am not aware of any legal proceedings toward advocates. We all carry E&O and liability insurance, but to date, I haven't heard. I mean, the one thing that I think is very important to understand, even if we have the skill set, we do not give medical advice, okay? And we do not perform medical functions. So we don't do dressing changes or anything like that, even if we have the skill set to do so, because that's not our job as advocates. I don't know if that helps.
Yeah, Wendy?
Thank you very much. I must say this was far more optimistic than I actually anticipated when I was coming, and I'm delighted to see that. And I was particularly heartened by your notes there that that things could be cost effective from the patient point of view, and that there may be some opportunity for insurer support, because having taught health insurance for God knows how many years, I think insurance rules the world. But I'm thinking about if that's true, there are also pressures on the providers. And you may very well have insurers saying, well, yes, we will pay for a patient advocate. But meanwhile, the providers are subject to rather different pressures, often with being squeezed, not having enough resources, not having enough staff, not having enough physicians, nurses, PAs, etc. Plenty of administrators, but not necessarily enough of the others. And they would say, we would love to have this, but now we only have 10 minutes per patient. So I wonder if that's become an issue. Have you seen that, or if you are worried about it?
Always worried about it. Always worried about things going even more awry than they already are. But as you saw, I was actually really very hopeful after seeing the survey response that over 60% of providers felt that having advocates really reduced a burden on them and their staff. So I think it might, help balance that out. That if you can, as I said, if you do the adequate prep or requisite prep beforehand, before you see the provider with your client, that you can concentrate on the things that really need to be discussed. And if you, one of the famous things that we talk about, most lucrative in this country, is cancer care.
That's
right?
true.
The moment you have a cancer diagnosis, a computer, usually AI probably, but at this point, spits out a treatment regimen. It's your chemo, it's your immunotherapy, it's your whatever. gives you a personalized cancer navigator. You go in to basically just receive that piece of paper that gives you the pathway forward without much discussion of the options, right? And the one option that is really never discussed is, what about doing nothing? Right? How do people do if they choose palliative care? And I want to be careful about saying doing nothing. I'm talking about, making sure somebody's comfortable, making sure their symptoms are managed. That's a longer discussion, and it doesn't happen because they only have 15 minutes.
I'm going to take a couple questions off the chat, and then we'll go back if we have. One of these you could have written, but I don't. Jane asks, how useful or effective are spouses and partners as patient advocates?
Well, it's always better to have somebody than to have nobody there. But, similarly, and I feel terrible about Anna, Cathy's sister, who was there that day, right? There's no way that Anna hasn't been traumatized by that experience as well. When you are with a loved one seeing things go awry, you are simply emotionally involved, and you cannot be as effective. I mean, again, it's better to have somebody than nobody. I've certainly advocated for mother, father, stepfather, husband, and myself as a critically ill patient. It's hard. It's hard when you're emotionally involved. And having somebody who has that extra, it changes the dynamic. I have no doubt that Anna did her best to advocate that day as well, but it changes the dynamic if you have somebody who's a professional, if you will.
No, I've always argued just get somebody in that room with you. But
Yeah.
You're absolutely right, though. You could traumatize them and make things worse.
It's horrible.
So having a
It's
trained
horrible.
person there is like night and day. I see.
Yeah.
Absolutely. Rosalind asks, what are the steps to become a certified patient advocate?
Well, you can go to the website.
Well, that's a good start. Actually, that is a good
No,
start.
it is. No, absolutely. Really, the information is all on the website. And thank heavens to Danielle Marshall, who's our executive director, who's the lifeblood of the organization, who has really mapped out everything beautifully. As I mentioned, there is an education and an experience pathway, so you don't have to go through it. There aren't enough training programs for healthcare advocacy. And again, this is, of course, where I feel schools of public health are natural allies and partners. Most of the courses actually already exist. You maybe have to tweak a couple, and you'd have that. And actually, at this point, if I may, there is a 4 BU undergrad students
That's true.
are working with the BU Innovation Lab. And they contacted me recently to let me know that they had had an experience where so many of their friends and classmates had absolutely no clue about healthcare, especially the international students, right? Remember, these international students now, they're here, they're without their parents, without their friends. They all are used to everybody has healthcare. They don't know anything about the US system and how they didn't know anything, how they weren't treated well or right. And so they decided, what if we got medical advocates for students? And so they're working on that. They had approached us. We've met, some of us from the Massachusetts group have met with them, which was terrific, and we look forward to helping them. But they are on track to create a blueprint, I think. And BU is the perfect school for it because it has such a large international body, right? And it's really not just for the international people. I mean, a survey shows that 4% of Americans can identify the important terms in health insurance. 4%. Right?
I didn't know it was that high, actually.
Yeah. So anyway, I mean, would it be great if we could establish a blueprint for a undergrad or a college system where medical advocacy is accessible to students, and possibly have a course here that feeds into one another? That would be one of my dreams. as an alum of the school.
Let me ask one more. Can you please explain a bit more about the difference between a patient advocate and a community health worker?
Well, community health workers, again, they tend to be licensed, and there's tremendous variability from state to state. So what they need to go through, what is required of them, really differs state to state. For a healthcare advocate, we have the requirements online. We are, not licensed. We do the certification, so it's a much, I think, possibly more accessible, or it's certainly less confining in terms of where you work. And I have actually, one of my colleagues is both a community health worker licensed in Rhode Island and is a board certified patient advocate. So she does both.
So you see all these organizations working together?
I do.
Okay.
I do.
That's
I think that's the best way that we can get the greatest coverage for the most people.
Last chance in the room if anybody has a question. As one. Yes, go ahead.
Hi. Thank you so much for Thank you so much for being here. I really, really appreciate it. As a student and someone with a rare disease with a bunch of misdiagnoses, and through the whole process, patient advocacy is something I'm really, really passionate about. So thank you so much for being here. I was wondering, I know you kind of touched on it a little bit, how you ensure, or in general, how to ensure that patient advocates are culturally humble and dealing with
Good point.
underserved populations who have different needs, and how, tying in with the social determinants of health, big buzzword, I know, and kind of how to ensure that patient advocates can deal with many different niche populations.
Well, thank you for the question, and you are absolutely right. There are advocates who specialize in rare diseases and in certain populations. We are also really trying to increase the diversity in the advocacy space, because in terms of independent patient advocates, unfortunately, we are a bunch of middle-aged white women that we are trying very, very hard to. We've established a scholarship at the PAC board for specifically historically disenfranchised or disadvantaged individuals, or people who work with special populations, to be able to sit for the exam for free and maintain their certification. We've changed the domains, or modified the domains, to include cultural humility is very much part of what we advocate for, and is in our, if you read through our papers and our skill sets, we aim for that. We're not there yet, but we're trying.
Okay, thank you. That was terrific, brother. I just thought that was great. Yeah. The challenges are unbelievable. I don't know if Dean Galea, I'm sure, wants to say goodbye, but just thank you so much.
I just want to echo thank you to Dr. Kummer for a really terrific talk, and I just want to reflect that Professor Annis, like you wrote about this 50 years ago. It must be a mix of pride, but also some
disappointment.
Regret, disappointment.
Yes, exactly,
but it's really, as I'm reflecting on this, as I'm reflecting on something that you wrote about, and now seeing it move through the decades, it's really interesting. It's really, I think, a testament to scholarship that changes the world and action that changes the world. So thank you very much, Professor Annis. Thank you, Dr. Kummer. Thank you, everybody, for joining us online and in person. Everybody have a good afternoon. Thank you.